Okay. Good afternoon. So for those who don't know me, I'm Robert Klein, Vice Chancellor for Academic and Student Affairs. Not someone who is full of platitudes, and this is a great event, but as someone who came from the School of Medicine to have to represent all three schools at the medical center, this is a really important event and one that I am excited about, and that it also includes members of the health system in terms of the conversations we've had with our guest speaker and for this event itself. So I'd like to welcome you. This is the second annual Faculty Academic Day. And extend a special welcome to our guests, Chrissy Daniels, who Dr. Samari will do the introduction and provide some background about. Academic Day is a half-day networking, learning opportunity intended for all faculty at KU Med Center across our three schools. In addition to our keynote speaker, there are 2 blocks of afternoon breakout sessions. We'll focus on the enhancement of teaching, scholarship, and learning. A full schedule of breakout sessions is provided in the back. Additionally, we hope that you'll join us from 4 to 5 p.m. for a networking poster session. I think Jenny on an optimistic day was expecting about 9 or 10 posters. There are 24. So there are a lot of people working within health professions in its broadest sense, education and interprofessional education that had their outcomes that they'd like to share with you. So it's held in conjunction with the 3rd Annual Interprofessional Preceptor Summit, which took place this morning. Special thank you to Christy Johnson. Thanks, Christy, and her team for putting on this summit. It's intended to provide preceptors with the tools to provide intentional interprofessional education and collaborative practice opportunities in real-world practice environments. So with that, we're going to move on to award presentations. I'd like to take a few moments to acknowledge individuals, some of whom have been recognized on the Lawrence campus, and we feel it's important for them to be recognized and for their accomplishments to be acknowledged at the medical center. So I'd like Dr. Samari to come up. I don't think Dr. Samari needs much introduction.
Then we won't have to do it.
We won't do it, okay. I'm gonna do these. You're just gonna hang out.
All right.
You're just gonna hang out. I wanted to tell yes, okay. So when Dr. Samari first arrived, we went down to the Wichita campus and
You're going to tell a story.
yes. And we went around the table to be introduced, and even though it wasn't really true, he said, I'm Rob Samari and I work for Robert. Well, it's amazing the way things change, because actually I now do work for Dr. Samari. So, okay, so the first group, these are individuals who received the Chancellor's Distinguished Teaching Award, and so they have been recognized at the KU Summit, but to be honest, very few of us trekked to Lawrence for that event, so it's important for us to recognize them here at the Medical Center. The Chancellor's Distinguished Teaching Award is intended to recognize and reward faculty who have demonstrated teaching ability of a clearly superlative nature. Recipients of this award are faculty who contribute to the university and its students through excellence and outstanding classroom teaching, and I'd say classroom in its broadest sense. Faculty can be nominated by students, by faculty members, and I'd like to note that most of the recipients nominators are here today, which is especially nice. So you can find a biography on each of the individuals, but starting, it looks like we are alphabetical today. So Paul Bennett, he's a clinical assistant professor in the Department of Nurse Anesthesia Education, School of Health Professions. If you come forward, we have a pin for you. I'd like to embarrass Paul. It's the second time I've ever seen him not dressed in green. So he spends a lot of time in the OR, and a lot of his educating our trainees and learners occurs in the OR. Thomas Farbach is an assistant professor in the Department of Diagnostic Radiology, School of Medicine. We're going to do a group picture. You are wearing green. Thanks. Susan Jackson is associate professor in the Department of Hearing and Speech. That's wrong, right? It's Department of Occupational Therapy. It was right. Why did I think you were an OT? I don't know. Okay. School of Health Professions. So my correction is wrong. There you go. Yeah, I should just stick with it. Jenny Mehmet doesn't make any mistakes. I make mistakes. Okay. Fourth, Wen Liu, associate professor in the Department of Physical Therapy and Rehab Sciences, School of Health Professions. Wen here. I guess it'll be a picture of three. So. The next group of awards, these are the Chancellor's Club Teaching Professorships, and they recognize sustained excellence in teaching are awarded only to persons who've demonstrated outstanding teaching competence over an extended period of years. Our recipients hold these chairs, which carry an annual stipend, as long as they remain active as teachers and full-time faculty members at the University of Kansas Medical Center. Although the KUMed recipients were recognized at the Chancellor's Club dinner on the Lawrence campus in October, we want to take this opportunity to recognize them again today. You can find details in terms of their biographies in the Academic Day booklet. In 2017, we were fortunate enough to have 2 of these prestigious professorships. Please come forward when I call your name. First, Gary Gronseth, professor and acting chair of the Department of Neurology, School of Medicine. Second, Karen Wambach, professor in the School of Nursing. Karen. Lastly, but not least, I'd like to recognize the 2017 recipient of the Glendon G. Cox Leadership Award. It's Dr. Roy Jensen. Dr. Jensen, would you step forward? And Dr. Cox is here today. Would you come forward too? So the Glendon Award, as we like to call it, kind of like Tonys and Emmys and Glendons, would not be possible without the generosity of Voya and Presswood Financial Group. Wendy and Mark Presswood are here today. Wendy and Mark, would you please stand to be recognized? We appreciate your support of numerous awards for the Medical Center. Thank you. The Glendon G. Cox Leadership Award honors a member of our academic medical community as a leader and recognizes contributions made in extraordinary fashion and at a consistently high level over a span of many years. The award is faculty initiated, recognizes our colleagues who have shown sustained leadership and excellence in any of the schools, excuse me, at the University of Kansas Medical Center. Just a few words about Dr. Jensen. Excuse me, sorry. It should be noted that he is, let's see, I want to go back with a few words. Under his leadership, KU became National Cancer Institute, designated as a cancer center in 2012. Seems like a long time ago. Only 25% of first-time applicants are successful in receiving the designation. In the past 12 years, annual cancer center funding has increased over $40 million, and multiple investigator funding has increased 30-fold, and largely due to the work of Dr. Jensen and his colleagues. Cancer Center is ranked 25th by U.S. World and News Report among cancer centers and top 10 center for bone marrow transplantation. These are remarkable accomplishments. Just this summer, the NCI renewed the Cancer Center's National Cancer Center designation for 5 years with an additional partner in Children's Mercy Hospital. The Cancer Center remains one of only 69 nationally recognized centers by NCI. These are just a few of Dr. Jensen's accomplishments and contributions. So, Dr. Jensen, we have some things for you. Glenn, would you?
Thank you so much, Robert, for your leadership and particularly up to today's event. So it's my pleasure to introduce our keynote speaker, Chrissy Daniels. Chrissy Daniels is a national thought leader in patient experience and healthcare value. She joined Press Ganey in August of 2017 and brings her to her role of consulting partner more than 20 years of experience in advancing the patient experience and building an engaging and collaborative culture. She is widely recognized for her pioneering work in the areas of consumerism and physician performance data transparency. Prior to joining Press Ganey, Chrissy was the Director of Strategic Initiatives at the University of Utah Healthcare, responsible for teaching and coaching physicians, leaders, and staff on the importance of patient experience as a measure of quality. In this role, she was responsible for designing the University of Utah's Healthcare's online physician review process, making the system the first in the country to electronically survey its patients and to post its results publicly online. In addition, Christy worked closely with hospital, physician, and executive leadership to drive cultural change around improving patient experience and value in every encounter across the system. This work resulted in system-wide initiatives targeting leadership and team development, communication, and motivation, which evolved into a model for cultural transformation. Prior to this work, Chrissy has led hospital and clinical operations for the University of Utah Healthcare. Among her accomplishments in this role was overseeing the $180 million of hospital construction projects, including two expansions of the University of Utah Hospital. In 2013, Chrissy was the recipient, with Dr. Robert Pendleton, Chief Medical Quality Officer, of a Robert Wood Johnson Grant Foundation to provide physicians and hospital administrators from around the United States a 12-month learning experience focused on the key drivers of high-value healthcare. And in the setting of recent opportunities to to discuss physician wellness and physician experience, it's really fitting to have Chrissy join us today to give this talk entitled Creating an Epidemic of Empathy. Chrissy, thank you for coming. Can we give you that?
Thank you. Yes. It is a delight to be in the halls of academic medicine. I had the warmest feeling when I was stroking the cinder block walls of the School of Medicine, because I've been 3 months out of academic medicine and I miss it very much. So I'll talk to you today largely as your colleague, thinking about how we not only deliver healthcare in today's tumultuous environment, but how do we prepare the clinicians of tomorrow to be more effective with their patients, more resilient in their practice, and more innovative in their improvements. And you're a very diverse group today. And so I felt challenged to make sure that everyone here would have at least one thing you could leave with. So I'm not going to start with that story. I'm going to start with the fact that I believe everyone will have at least one thing that they can use either in their curriculum development, their personal practice, their precepting of students, or your personal reading, and we're going to accomplish all that in an hour. But first, I'm going to start with the story. My role in patient experience started probably in a way that's familiar to many of you, where you're sitting in your office, you have a day job, and someone comes in and says, I have a great opportunity, and you're a person who can get things done, so can you help me on this? How many of you have had, I think we just saw 8 people who have had that conversation, including Dr. Samari, who probably had that conversation. So in 2002, I got a note from my then CEO. It was just a note. He didn't even ask for a meeting. This was literally, it was an email where he said, I want it to feel better around here. I want patients to be happy, and I want physicians to be happy, and I want staff to be happy. Bring me a plan. And I remember this very, very clearly, that 1 week before, a colleague of mine had explained to me that there was a thing called Google, where you could look stuff up and learn things that were on the internet. And the very first time I used Google is when I wrote hospital culture change and saw what popped up. There was nothing. So that was disappointing. But back in 2002, I had a challenge to come to experience, not just to improve an CAHPS score, not just to improve our value-based purchasing performance, not to meet a clear requirement for integrating trainees in hospital operations, but because it needed to feel better and everyone needed to be happier. So I said, sure, just like all of you say sure. And here we are 15 years later. I'm going to talk to you a bit about the University of Utah because we're so similar. Have any of you been to the University of Utah? We're a lot alike, don't you think? It's shocking. So, only academic medical center in one state. How many states does KU serve? They don't have academic medical center in South Dakota. Just one? I serve 5. Utah serves 5 states in the Intermountain West. Our catchment area is 800 miles. No shortage of patients. Physicians are very, very busy. Lots of patients waiting. No need to compete on market. We have a comprehensive cancer center. We have all sorts of trainees. We built a dental school 2 years ago, and I hear you guys are considering that. Vizient, formerly UHC, top 10 for how many years running at Kansas? Do you guys know? I think 10. Utah, 8, in the 8 years as one of the top-rated academic medical centers in the U.S. Not that anyone on the coast ever acknowledged either of us, so I know about that too. And so I come to you as a person who's worked to develop curriculum, understand the constraints you're in. We want to teach our trainees everything. We have no time to train them. Hours are constantly constrained. So how do we think about this? Why should you listen to me? Why you should listen to me is that in 2009, Utah looked like a lot of places in America where we had about 1% of our doctors in the top 1% in the country. A little below average because we had about only 4% in the top 10%. Last year, almost 30% of our doctors were rated top 1% in the country. And then total 41%, including that 30% in the top 10%. We have been able to transform practice. Those doctors did not have protected time. They did not have extensive didactic training. The patient experience office can sit on one half of one of these tables. But we have transformed culture. And that's what we're going to talk about today. How do you start to lay the groundwork, the aligning infrastructure to prepare every one of your trainees and all of your faculty to be distinguished in this area? So I'm going to talk about 3 things. The history and present state of U.S. patient experience measurement. Why am I talking about that? Because many of you will have to incorporate some elements of this in your curriculum, and I'm giving you slides that you can copy and not create. Practical. Second is that we're going to talk about some statistical analysis of what are the drivers of patient trust and loyalty in healthcare. This is analysis that you can only get from Press Ganey because Press Ganey is the only organization in the country outside of CMS that has access to a big enough data set. We have analysis that we can cover 1 million patients from across the country, which allows us to very, very carefully dig through that data to find correlation that a smaller data set would not permit. Third thing is that we're going to give you 3 practical ways that you can influence your own practice or influence the practice, explain your practice to the people you're precepting. What I find most remarkable is that the people who are best with patients often have the hardest time teaching others how to do it. We have a lot of natural athletes in the patient experience space. We just are good. I've shadowed, I don't know how many doctors, know how many nurses, and I say, how did you just create rapport? And they look at me and say, I don't know. So I want to give you a model so that you can start deconstructing your own practice so you can do it more consistently and you can teach others how to do it. So, little background on patient experience. Patient experience is work that's been developing over the past 25, 30 years. Nearly 30 years ago, we started to see the idea of patient advocacy evolve, where patient groups were organizing around bringing the needs of patients to the delivery of care. You would see like the March of Dimes Society, the MS Society, Muscular Dystrophy Association. People organizing around patient needs and bringing their voice to delivery of care. Shortly thereafter, the Joint Commission required through CMS, as part of the conditions of participation, every hospital was required to start measuring patient satisfaction. CMS began to design what they called a voluntary measurement of patient experience. They spent almost 7 years sorting through how they would measure the patient voice in healthcare. The National Quality Foundation began to define patient experience measures as the first patient-reported outcomes. In the early 2000s, CMS required participation in CAHPS for full reimbursement for hospital care. And they have continued to evolve the value-based payment program. Every single one of the value-based program initiatives includes patient experience as a component. The way that CAHPS, which is something that is a reality, regardless of administration, no one has talked about removing CAHPS. There's a lot of talks about change in healthcare reform. Value-based purchasing is a bipartisan supported initiative, and no one has talked about changing value-based purchasing as an evolving cost control method for federal spending in healthcare. The way they do it, it's usually about a 7-year process. They field test a survey. The AHRQ, the Quality Forum, brings together national thought leaders to contribute to the conversation. Usually there's a 18-month period for pay for reporting, and then that quickly moves into a pay for performance space. These are sample questions, and what you would look at is what the survey is trying to measure. There was a philosophical embracing by CAHPS that they would focus on the frequency of process as the measure. This, my colleague Tom Lee talks about, he was actively involved in the Boston camp versus the Illinois camp. The Boston camp wanted frequency. The Illinois camp wanted patients' perceptions of care. The Boston camp was well-positioned and well-connected, and the Boston camp won. And so now always is part of many of our vocabularies. And what CAHPS measures tend to focus on is the frequency of process success. They look in communication for consistent things. They want patients to be listened to. They want respect to be perceived. And they want patients to understand things. This is a weighting of current value-based purchasing reimbursement. Right now, 2% is at risk for hospitals, which is the most mature value-based purchasing tool. And it's divided between safety, clinical efficiency, quality of the processes, and patient experience. So patient experience is about 0.5% of reimbursement. No one would work on this for the money. There's a lot easier ways to make money. 0.5% of your inpatient revenue. You guys are growing like crazy. You say 0.5%, why would I do this? So while there is a financial incentive, it's not reason enough to do this work. We're used to looking at inpatient CAHPS. What I would like to point out is the enormous expansion of CAHPS projected over the next 3 years. Pediatric inpatient CAHPS, ambulatory surgery CAHPS, ED CAHPS, home health CAHPS, hospice CAHPS, inpatient psych CAHPS, dialysis CAHPS, ACO CAHPS, and then PQRS, MIPS CAHPS. The federal government has evidence that shows that CAHPS is transforming the delivery of care for patients nationally. And they are quite certain it's working to achieve what they wanted it to achieve. That may feel different in our individual practice areas, but as a nation, it's having impact, and that impact is measurable. And that, I think, is the end. Any questions? No one usually does. We wish it would go away. We don't want to think about these surveys, but surveys are here and they're here to stay. They are part of our reality and our performance being measured in this way. However flawed those instruments may be, CMS is quite pleased with the outcomes they're achieving and are unlikely to change them. If you do have the opportunity as a thought leader to be involved, please avail yourself of that opportunity. I would believe that there are people here who have the opportunity to participate in those CMS forums, and I would encourage you to participate. Utah's taken an active role over the last 3 years to be present with CMS influencing policy, and I believe that you have that opportunity too. And if you don't like the way the surveys and measures are set up, you can make a difference. So if you want to talk about how you can be involved in those forums, I'm quite certain that CMS would be very interested in what KU Medicine has to say about the development of these measures. Second thing we're going to talk about is, so we have these surveys, however flawed they are. I would be glad to talk to you about the flaws of the survey. I've spent at least 5 years of my life talking about the flaws of the survey. I agree with the limitations of the instrument, but there is no perfect data, and it's the data we have. So the question is, why would we ask patients what they think about medicine anyway? What do they know? What do patients know? I have doctor colleagues who say, I barely know who's a good doctor, and I'm a doctor. If I don't practice with them, I don't know, so why would we ask patients? They think that this is a hotel. They think I'm here to take care of them. They're unreasonable. What is it that patients really want? Well, I'm here to tell you that this should give you a lot of reinforcement for specifically the development of curriculum here at KU. Because what patients really want, they're quite sure this is not a hotel or a spa. What they're trying to discern and what makes them have trust and loyalty with us is that they have peace of mind. That is what patients want from us, peace of mind. Sometimes we can cure them, sometimes we can't. They're well aware of that. In the moment, I know they're disappointed. But they know they want three things. They want confidence in our skill. This is actually a regression analysis of over 1.4 million patients. I can give you the white paper on this afterwards so that you can look at all the very extreme amount of detail. And we tried to find what are the predictors of trust. What is it that would lead a patient to recommend a physician? This is in clinic. And what we found is that about 16% of patients fail to recommend their providers. And when we analyze why is there a failure, well, probably the more positive is what leads to a 97% reliably predicted likelihood to recommend. Three things have to happen in unison. One, the most important, is that they have confidence in the skill of the provider. If people have high confidence in the skill of the provider, 98% of them will recommend. The second driver is that the team work together. They perceive that unsafe care happens in transitions and in poor handoffs, and they can discern that. And then the third thing is the concern for worries. So if we have one of those things happen, if I don't have confidence in my provider, but the team works together and they listen carefully, I can only get to about a 50% likelihood of recommending. So there's three things. It is not wait time. Can I say that again? It is not wait time. If they understand, they're willing to wait. They know the difference. But how does that reflect on the inpatient side? Again, They value coordination of care. They perceive that when we're not working together, that they're not safe. They want the room to be clean. Why would room cleanliness be so top of mind for patients? Why? It's a safety issue. They are very afraid of infection. And the last is that we listen. All of these are safety indicators. If we were going to create a system that had safe, reliable care, where do we break down as a care delivery system in safety? Handoffs, infection. We don't pick up on all the signals. So patients actually are able to perceive safety, and that is what they're looking for. In the emergency room, again, interestingly, staff cared about you. If staff care about you, then you can stay in the emergency room for a very long time and not be unsatisfied. That the doctor was able to keep you informed about what would happen and that you have information about your delays. They recognize that they will have delays. No one goes to an emergency department for efficient care. What they want is responsive care. So as you think about developing curriculum, empathy is present. Staff caring about you as a person, doctors' concern for your comfort, the nurse's attention to your needs. They have ways that they perceive that empathy occurs. These are the most correlated with patient trust. A lot of teamwork, which is what the work you're doing to incorporate team steps, really provocative, quite an interesting adoption that I study how curriculum is implemented and have spent years looking at it. I applaud you for taking a proven methodology, not debating it into the ground, and just working on reinforcing across the continuum. It's really remarkable work. And then, do I have information? Can I take care of myself? So, that is the practical background. So for those of you who don't take care of patients and don't precept people who take care of patients, but you teach courses that are on some kind of like healthcare reform, I hope you can use some of these slides. All of those studies have white papers that are exhaustive, and I can share them with you. You have access to them at any time. Now let's talk about influencing practice, because creating an epidemic of empathy is not necessarily something. How do you think that you actually do it? How do you do it right now? How do you teach empathy? Teaching word people? I just got teaching. Like, how do you teach empathy? You show it. What do you say? You role model. Role model. I'll just do an informal poll. In other industries, not medicine, not nursing, they actually look at the experiences they have managing difficult conversations as something that's called emotional labor. They call it emotional labor, like flight attendants have emotional labor. But interestingly, doctors and nurses have never studied the emotional labor of the work that they do. What percentage of the draining, the stress that you have that leaves you undone is related to the emotional labor of difficult conversations, either with patients or team members? Would you say it's in the top 3? It's only in the top 3 when you're having a good day, because when it's the bad day, it's number 1. The emotion, if you have a conversation that goes poorly, how long does it affect you? How long? Just that day? You go home, do you think about it at night? You take it home with you? How many of you have had a conversation that has worn on you for more than a month? How many of you have watched a trainee who's had a poor conversation? I will just say, think about the trainee who has the difficult conversation in the first month of residency, and it damages them for a year. They start to withdraw. They're not confident in their own skill. They don't know if they can manage things. I've seen that happen. So it can be a very, very difficult thing. And the amazing thing to me is, I would say healthcare has the highest proportion of extremely emotional-laden conversations in the daily work. And we don't use a cognitive framework or provide adequate preparation to have those conversations. We throw you in the pool and hope you learn to swim. We've relied on the intelligence, empathy, and passion of clinicians for years at the cost of their mental health. So if you take one thing away from today, I will say this. We have an opportunity to provide, much like we have decided to do here with teamwork, we have the opportunity to provide a cognitive framework to understand communication so that people can deconstruct their own practice and learn from it. And I will say the reason to do that is not to improve patient satisfaction or patient experience. The reason to do that is to reduce provider cognitive load. And I've seen that happen. When you offer a communication course in an academic health center and it's voluntary, do you only bring the doctors who need help when you're trying to create institutional buy-in? Nah, you got to go to your doctors who will give it a shot. So I went and got all my good doctors. I'm like, come on, come take this class. I need you to take this class and tell us how to make it work. We had a few physicians who were struggling, but 80% of the people who went through the course were very high performers in patient experience. And all of them reported a reduction in stress as a result of going through the course. So I will encourage you to think hard and long about how do we find a model. I don't think there's any perfect model. There's a lot of models out there. All of them are fairly simple. But for the well-being of those who deliver care, adopting a model of communication reduces the emotional labor of the hard conversations we have. So that's my one recommendation. But in the meantime, what if you wanted to get better right now and you had $0 and 0 time and 0 additional FTEs to do it? Could I give you 3 practical ways that you could either improve your own practice or bring some practice deconstruction to your training? I'm going to give you 3 that I know work. We use them all the time. The first is the most powerful, which is to create a sense of shared purpose. Until we create a sense of shared purpose, really no progress is possible. I'll turn your attention to an article by Toby Cosgrove and Tom Lee called Engaging Physicians in the Revolution. It's a Harvard Business Review article about 4 years ago. They said there's 4 things that need to be present to motivate institutional change: shared purpose, institutional norms, affection for colleagues, and finances. But they said none of them work without shared purpose. And shared purpose is really what elevated Utah's work. And we're going to start with this question of why do I care about patient experience? People don't care about scores. I've never met anyone who cares about a patient satisfaction score. I barely care about patient satisfaction scores. I really don't. I care about making a difference in healthcare. And creating shared purpose begins with stories, not data. Many people who start to have conversations with caregivers about patient experience bring the data, but they overlook the story, and that those stories that crystallize what we're doing are those that show us how we want to be seen. So, what are the KU stories? What stories are we proud of here? I think we'd be pretty proud to be NCI designated. I'm proud of that. That's pretty great. You guys, one of the highest quality health systems in America. I'm pretty proud about that. What's a patient story that we're proud of here? Does anyone have like something great that's happened here? None of you? Yeah, good. Yeah.
She didn't accept that. She came. Bye, this Christmas.
So a patient who had been told that she had no hope, advocated for herself, directed herself here, was eligible for a clinical trial, is still alive. That's great. That's fantastic. If KU wasn't here, that would never have happened. I'm sure there's actually a patient that I could find easily who didn't have a good outcome, who was just as grateful for the care they received here. Families who donated money who we didn't save because of the experience of care they've had. So what is it that how do we find these stories? Like, I just asked you right here, like, how do you find patient stories? I'm going to give you a totally free and easy way to do that, which is, first I'm going to tell you the stories I want you to look for. Exceptional experiences involve caring, listening, explaining, teamwork, and efficiency. If you want to be great, you have to have all of it. You can't out-care your way out of an inefficient experience. You can't out-listen your way out of an uncoordinated experience. I want you to start looking for all 5 of these. And if I would have had access to your patient satisfaction data from last week, I would have found one. Here's what patients are looking for. They want to be known. They want to be heard. They want to learn. So this is what we're looking for. If you know what you're looking for, you'll start seeing the stories. So when I hear the story about the patient with the clinical trial, what I'm looking for is she referred herself and someone answered the phone. We were coordinated enough that we could get her in a clinical trial quickly. She could learn about her disease, and the teamwork made it happen. So it's not just that she got in the clinical trial. All those things had to work for that to happen. Here's a story that came from Utah. I wish you knew Dr. Grice. I think you probably do. If I told you who he was, I bet you know someone here who is just like him. He is a grouchy sports medicine orthopedic surgeon. Super grouchy. Like, really, people don't know if he can smile. So grouchy. So grouchy. Tall, grouchy, difficult, complains about everything. And this came in randomly. At Utah, we read every comment that comes from patients, and we pick the story of the week. Every week, something amazing is happening. Actually, we pick the top 10. It's very hot competition to be in the top 10. being in the top 10. Even people who have inconsistent performance can have a top 10 story. And we do it because we know the best way to think about how to do this work is to focus on when we're great. So patients write you little novels on the survey, which would surprise you. How many of you think that only angry people answer the survey? Not true. And when you use electronic survey, they don't know, they think you're reading, but they write you little notes. They would always write us and say, we don't know if anyone's reading this. And then we would always email them and say, yes, we are. But this is one patient who wrote this love letter to grouchy Dr. Grice. And you can tell him I said that if I have any orthopedic surgeons here. Tell him that I was talking trash about him, but that I showed you this awesome story, and he'll be really happy. Wow, completely blown away by Dr. Grice and his staff. What a wonderful experience I was provided. He's so caring, intelligent, and even has a sense of humor. I had a complete ACL tear and a meniscus tear, and he replaced my ACL with donors so it won't take as long to heal. Who taught this patient that? You think they came knowing that if you use donor tissue, it takes less time to heal? Which is important to me because I'm a wife and a mother of 4, and one of my children is a newborn. Who writes? I'm just telling you, they write us a lot of stuff. I notice your office does a lot of famous sports people's surgeries, and I think Dr. Grice is the surgeon for those people. He does, you know that guy? The guy who puts the pictures of the famous patients in the waiting? Yeah, that's who he is. He is so awesome and good to me, and he treated me just as good as those famous people. Thank you, Dr. Grice, for being refreshingly caring and friendly. A rarity. I would recommend him to anyone. Now, I guarantee you there's 10 stories just like this that came in last week here. Probably 20. We had what we called the throwdown. We would pick the top 25. Then my office would have what we call the throwdown. And we would vote which ones would be in the top 10 because it was always so competitive. Do we spend enough time talking about these stories? So I'll tell you that we send out a report with the top 10, and then my chief medical officer emails the doctor, the division chief, and the chair, and the vice president of all the people who are in the top 10 every week. When's the last time someone sent something really positive about you to your division chief, chair, and chancellor? How long do you think that makes you feel good? About how awesome you are with patients. It's not so bad. We do it for nurses, we do it for pharmacists, we do it for everyone. Stories tell a tale. So I can give you that model, care, listen, explain, teamwork and coordination, or you can read this story. The story teaches you because that's the kind of care we want to deliver. Okay, let's keep it real. This is my life. I've had 20 years, and I literally had a very big, honest conversation with the people who planned this conference. And I said, they don't want to hear from me. No one has ever wanted to hear from the patient experience person. No one has ever said this. This is a poster in my office where it says, I literally don't want to hear what you have to say. You're the patient experience person. You're my enemy. You're my nemesis. My colleagues who work for Ganey say, never wear your name tag on a plane because you'll be sitting next to a doctor for 2 hours and they know you work at Ganey and, that's going to be an earful. No one ever wants to hear about this. And I will say, I get it. Because people talk about patient experience in the most annoying ways. They're always telling you to make eye contact, which is creepy. Very quickly, I'm already creeping this guy out. He's creeped right now. Cole is stop with the eye contact. Any customer service strategy is creepy without the right intent. So we, at Utah, my method is not to teach people anything. It's to talk about intrinsic motivation. So this is the very practical part of the day. Get out your notebook. I want you to think about you. How do you want patients to describe you? When they leave your care, 3 words. We're going to do this right now. So I gave people some possibilities because they can't always think of something. How do you want to be described as a clinician? How do you want to be described? You can choose. No bad answers. You don't have to use these words. Any words you want. You realize that you're going to be described, of course. You know that they go home and talk about you. Once they've seen you, nothing else is on the agenda for dinner. The text, like while they leave your office, the texting has already started. So what do you want them to say about you? I will wait while you choose your 3 words. So who will share their 3 words? Who will share? Anyone? Oh, you're getting volunteered. Yes, Christy. Yeah? Yeah? Oh, she's got a double, caring and compassionate. Great. Does anyone have words that do not involve caring and compassion? P.S. That is not a trick question, and that is not a wrong answer. I want someone to be honest. If not, I'll use my examples of my doctors who are like, caring is optional for me. I'm okay with that. What if the answer was safe, expert, efficient? Who would like to see a provider who was safe, expert, and efficient? I would love to. Caring, compassionate, knowledgeable, love that too. There is no, the mystery of patient experience is there's no bad answer. Patient experience isn't about changing who you are. It's about being your best all the time. So the first step is you have to define what your best is. And this is the biggest barrier for most of my physicians. They didn't know the experience they were trying to deliver. They didn't have it crystallized in their head. So they couldn't be consistent. So when you look at that percent of doctors who were in the 99th percentile, the only training most of them got was this. Decide who you're going to be and be it. You have a desire to be trusted by your patients. You just have to figure out how that's going to happen. So you start with the 3 words that the experience you're trying to create. And then my next question is, what are you going to do with every patient to ensure that happens? So if I come back to you, Christy, expert, caring, compassionate, how do you tell them that you're expert? Like, what do you do? Do you introduce yourself? Do you talk about your training? How do you explain that? You know who's very good at introducing expertise? Surgeons are marvelous at it. I've watched a lot of them. They're super comfortable creating trust because they know that that's how we get trust. So that is a very comfortable strategy. If you want to learn how to do that, you want to teach a bunch of new internal medicine residents how to create confidence, you have a surgeon come in and tell them how to do it because they're creating confidence all the time. Caring, how do you show you care? There are strategies, and that's where I can help you. Stephanie Klein is a dermatologist at the University of Utah, marvelous dermatologist who did not inspire the confidence of her patients. She's nervous. She's twitchy. You want to like settle her down while you're meeting with her. You kind of worry about her. You say, "Are you going to be okay? Let me get you some water. We're going to settle you down." She had a vision for herself, and once she said it out loud, we could start working on it. And the most important thing is she had to explain it to her team. This is what we're going for in our practice. We're going to be responsive. We're going to be expert. We're going to listen. We can't do everything. That's what we're doing. The way we're going to be responsive is we're going to Ask them if they have any worries before they come in, and before they leave, we're going to make sure we covered them. You know, the team, because she was so twitchy, the team actually managed her up before she came in the room. They would tell the patient how good she was. Because she's very humble, and she's not a self-promoter. So we actually had the team would tell her patients how good she was and how famous she was, how amazing she was. So there's a way to do it. Once you say it, you can do it. The next tool is a tool that ties this all together, which is, there's a great book that came out this last year. Angela Duckworth is a psychologist at the University of Pennsylvania, and she studied excellence. What predicts excellence? What predicts an Olympic gold medal? What predicts amazing medical careers? She studied people who were excellent and tried to deconstruct what made them different from other people, and the answer was not IQ, and it wasn't talent, and it wasn't emotional intelligence. It was something she calls grit, which is perseverance. And she said that you can't be amazing at anything without three things. The first is you have to be personally passionate about it. Not because your mom told you to do it, not because your professor told you to do it, but because you have this kernel of personal passion. So we look at these great teachers who just got recognized today, and if we interviewed them, there will be a time when they said, teaching is my passion. That passion has to be connected to something bigger and outside of you. You have to see how that passion can make a difference in the world, and that is purpose. But the last thing is deliberately practicing. You have to want to get better. You have to think about what you're doing and consciously work on improving in a continuous way. So the last thing I'm going to leave you with is this great tool that came out like 7 days ago. Does anyone read New England Journal of Medicine Catalyst? Okay, everyone read New England Journal of Medicine Catalyst. It's free. It's on your phone. It's electronic. It's a New England Journal of Medicine's quality improvement journal. Not only should you be reading it, I bet you could all get published in it. You should be sharing what you're doing around training. They're very, very interested in innovative ways to incorporate improvement and value into training the healthcare providers of tomorrow. It's a fantastic forum. You got to check it out. And now you're going to want to, because you're going to get this free idea that you're all going to use. Dale Glenn is a doctor in Hawaii. I talked to him after he published this article. Now I just call people constantly. If anyone has a good idea, I just pick up the phone. I find out how to find them, and I call him. I called Dale in Hawaii. It was very middle of the night for me, so that was hard, but I did get a hold of him. And Dale is a doctor who believes in this idea of purposeful practice, and he talks about improving communication skills as a ritual. This is his really great wording. A ritual is a primitive checklist, a series of steps that, when repeated consistently, foster feelings of safety and trust between clients and caregivers. He's kind of like us, out in the real world, delivering medicine, no endowed chair, no protected time, improving while he's doing. He's a great guy. So what he did was this is not, the checklist is great and you can use it right now. The checklist was grounded in the literature of proven approaches that increase trust between patients and caregivers. But what is innovative is how he rolled it out. He said, and you can start to see the parallels, you're probably doing some of these things. I want you to check all the stuff you already do, and I want you to just keep doing that. But I want you to think about it. And then I want you to choose 2 more. In 1 year, in his group of 250 physicians, they went from the 35th percentile to the 75th percentile, just by making the practice deliberate. Can you see the connection? It's not what we're doing, it's that we're conscious of what we're doing and we're doing it all the time. If you are trying to create a module on trusting behaviors, feel free to use this, courtesy of Dr. Glenn. He would love to hear from you and see what you have to do. And if you're using it with your trainees, please email him. I'll send you his email address. He'd be very excited about this. I'm actually emailing him after I give this talk, because I told him I was going to talk about his article in this forum. He was very excited that people in Kansas might be able to give him some feedback on his work. But as a person who's developed a lot of undergraduate curriculum, this is like a really awesome cheat sheet, and I would totally steal that or borrow it or cite it. And you can get that, and I've given the connection right there. So, last thing I'm going to leave you with is a bibliography. In my experience, faculty are much faster readers than listeners. And if I give you something, these are all sort of 5 great resources that I think will help a lot, at least half on teaming. I think teaming and the work you're doing on teaming is crucial to the patient experience. But also if you want to have a little more grounding in the practical application of patient experience, I recommend Epidemic of Empathy by Tom Lee. It's a fantastic book. It's the reason I work at Press Ganey. Tom Lee thinks about patient experience and healthcare delivery in a way that is leading in America, and I took the job at Press Ganey to work with him. Antidote to Suffering is written for frontline nurses to help manage the cognitive load of nursing and for nurse leaders who struggle with how to keep that focused. Team of Teams is a marvelous book on teaming. If any of you are history-oriented, Stanley McChrystal wrote this about the invasion in Afghanistan. It's an amazing book. It's a fantastic read. Totally recommend that. Allison Offrey's a physician at Bellevue in New York. Really practical book around how to improve your listening skills. Very, very good. And then Amy Edmondson, you may know her work. She is the originator of the phrase safety culture. She's an amazing thinker at the Harvard Business School, and that is a book that I think you could use to take your team-based curriculum and practicums to the next level. All of those are great. So I hope we accomplished that you can understand the measurement piece, that patients value skill, teamwork, and empathy. They are not confused, and they value it because they want peace of mind and safety. And that activating and directing intrinsic motivation is the key to improving patient experience. And with that, I'm right on schedule. We have a few minutes for any questions you might have, and we can talk practically. Oh, how fancy.
Amy, Chrissy, thank you so much for the great information and feedback. How, as a team, with you all I know, isn't it neat? With you all sort of having your own 3 things that guide your vision for your practice, how can you all, as a team, all get on the same page if you have, different goals for how you see care?
The first step is to understand where you're like and where we're different. Because we don't have a vocabulary or framework to talk about it now, I just assume you're like me. We don't have any conversation. I think the ability to organize around the needs of patients is you need a diverse team. So part of it is, here's how I want my patients to feel about me. Now we can have a conversation about how do we want all of our patients to feel about our care. Mm-hmm. And I've seen that happen very effectively, most effectively in closed units where they have dedicated physician staffing, but certainly on the nurse manager level, I've seen it happen programmatically with teams of therapists. And then at the practice level, aligning with physician and their assistive personnel in their practice.
Thank you so much for that. There have been some that have suggested that patient feedback regarding levels of pain control have had consequences that go beyond just the patient experience.
Right.
Can you, what do you think?
Okay, so I am very troubled about opioid dependency, and Utah is right up there. If you want to take note of number one in prescription medication abuse in the country, not just opioids, but everything, Utah. So that's probably a consequence because we just don't drink enough, but we got to use something else. But I think that it needs to not be a distraction. I think that it's important for us to monitor patient pain. But at Utah, we stopped counting how well the patient-reported outcome, which is how well was your pain controlled, and we focused entirely on did staff work together to control your pain. We've spent a lot of time being more honest with patients about pain. That's probably been our biggest takeaway, which is that by not talking about pain, we let patients bring their own assumptions, which included, I won't have pain after surgery, which was not a positive. We often left it to our inpatient nurses to talk about, and so we started talking about pain much more in clinic for planned surgery. We have a very good tool on New England Journal of Medicine Catalyst, which is non-medication interventions on pain that we modeled on our medicine unit to great impact, and I'll send you the site for that, and we actually gave you the toolkit and the interventions. We found that when we talked about pain and gave our non-nursing, like our nurses' aides did the intervention for non-medical aids in pain. And we were able to give people options other than medication. A lot of our patients are afraid of pain meds. They're afraid to get addicted to them. And so it's not that they all want them. But I do think right now it puts physicians, especially in a zero-sum game, to critically judge how they're perceived in managing pain at the same time that they have enormous pressure to reduce the use of prescription narcotics. So we just stopped talking about it and focused on communication.
Will it be removed from service?
It is removed. It was removed last year by CMS from CAHPS with a focus on communication about the pain. That people understand their pain, but not that their pain is always controlled. Yeah.
Hi there. I want to thank you for this because I've been waiting for you.
Oh, good. Here I am.
But not in a kind way, I have to tell you. So you changed my perspective in coming in today.
Oh, good.
I'll be honest. So my background is emergency medicine. When we talk about pain coming in there, you're talking about surgical. But I'd like to talk about and I saw pain up there as number 3, when the scores are used in a punitive way, and that has become a very large trend in emergency care. And we have an enormous amount of seekers.
Yes.
And let's not just do pain medication. Let's just talk about the trend in antibiotic seekers too, who feel that their payment of service requires a prescription in general. And so dissatisfaction comes into those surveys. When they're used punitively, then people are losing their jobs. You get greater employee dissatisfaction. I had a student do a small little capstone pilot study, and that's actually the question that was asked was, what was the driving force for you writing a prescription? And patient satisfaction score was number 1 on there, which was very concerning, which was not a surprise because they have been driven for RVUs and things like that in practice. So I was hoping that you could address that.
Sure.
But I do want to commend you and thank you because you really did change my perspective today of what I came in thinking about.
Well, I've spent a lot of time with people. I do think that when we use data for improvement versus evaluation, it changes the tone. I will tell you, at Utah, it was only used for improvement. So what we did, we didn't use it to evaluate performance, but we were transparent across the organization all the time. So you weren't penalized for performing poorly, but you did know that you were performing poorly, and you did know that you're performing poorly relative to your colleagues, and you were offered resources to help improve performance. But I think it's not so much what's wrong with you, but why is it the way it is? I mean, I think a lot of people say you just need to improve, but I think more time needs to be spent understanding the nuances of every situation. So I will tell you, we were not supportive of blanket tactical interventions in any area. We were very supportive of aligning the team to use the information to try to learn from it and improve. So if you looked at your data and we would say, what can you learn from that data? If you can understand, we'll help you analyze it if you need to, but what looks to be true for your area? And then how do we organize the team to help you do that? And what resources do you need to improve? And where do you want to start? You know there's problems. Which ones do you want to work on? And so part of it was not over, it's just a data point, but it's an important one.
So is that something that you addressed
Mm-hmm.
to facilities?
Yes. Yes. I'm at the University of Cincinnati right now. Like, literally, I was just there. And that's what we're talking about, which is how do we turn this into a conversation? Everyone wants to be great with their patients. It's not a us-them thing. The patients are not the enemy. The question is, how do we organize around their needs, and then how do we create alignment so that that can happen? And I believe that when we do that, we see transformation. I didn't have any hammers, so I had to use a lot of carrots. And the carrots are for the people who win, and that most people have intrinsic motivation to get better. But I do have some good resources for you around emergency medicine specifically, which I will send you some really interesting thought leaders in emergency medicine who are super practical and marvelous. People at Sharp. I have a leadership team at Utah who kind of deal with the hard. Not all EDs are the same.
No, and I think,
Mm-hmm.
I'm not going to be able to change the patient in this one visit, so give him 10 and get him out the door.
Yeah.
That doesn't carry on, but then that results into a poor score on a survey because one was willing to do the battle, offer resources.
Yeah.
To say that sounds a bit aggressive,
my approach has always been, if you think it's true and you think that's affecting your scores, let's figure out how we figure it out. Because you can look at your data and figure it out. You can see, who are drug seekers we saw? Did they fill out a survey? Did they rate us lower? I can figure that out. So let's let the data inform our thinking.
I think it's just not going to that next step and level.
This is complicated. There's no easy solutions.
Right.
It's complicated.
Thank you.
We're out of time. You need a break. So I am so grateful to have been invited here. This is such a marvelous place. Congratulations on the outstanding quality of care you delivered to patients. It is remarkable what you're doing here.
Which where? No, I haven't. Which corner? Start. Okay.